So, respected teacher, my respected chairpersons, the panelists, and the distinguished audience. I'll go few words with regarding the prosthetic cardiac valves, its echocardiographic assessment. And my talks is arranged in this manner. I will talk on types of prosthetic valve, then normal characteristics of the prosthetic valve, then role of echo in prosthetic valve, and echocardiographic features of normally functioning prosthetic valve, and the echo characteristics of the dysfunctional prosthetic valve. The patient prosthesis mismatch, and at the end take home my message, and ultimately I will show some video clip. And so after discussion of so much learning topics, I want to just relieve the imagination center. This is the drawing of Greek mythology. She is the echo, symbol of sound, and he is the Narcissus, most handsome man in Greek mythology, who sees his own image in water, tries to capture it, and died. So he is the symbol of image. He is the sound, he is the image. So echo is composed of sound and image. Now, what is prosthetic heart valves? These are artificial heart valves implanted into the heart of a patient to replace the dysfunctional native heart valves. These are the types of prosthetic heart valves. So mechanical, bioprosthesis of tissue valves, homograph valves, valve conduits. These again may be biological conduit with stented tissue valve or mechanical valve, and artificial conduit with stented tissue valve or mechanical valve. Autograft, regarding autograft, actually autograft is not a prosthesis. As for example, in Ross procedure, the pulmonary valve is implanted in the aortic position. That is the native valve in the same person. So these are the types of mechanical valves. These are ball and cage, single disc, biliped. This is first generation, second generation, and third generation valve. And these are some types of bioprosthetic valve. Bioprosthetic valve again may be with stent and without stent. It may be stent with Carpentier-Edward or pericardial with stent, Carpentier-Edward Magna. And these are some stent-placed valve and homograft. This is the picture of the Star-Edward cage ball valves. This is the swing ring, this is the metallic cage, and this is the ball. And you can see the ball in cage Star-Edward valve. This is the flow pattern around the valve. And this is a single disc mechanical valve. And you can see this is a swing ring, and this is the metallic frame, and this is the disc. And there are two orifices, one the major, another the minor. And this is the flow around the single disc valve. And you can see the biliped valve. This is the most important because it is widely used in our clinical practice. And this is the metallic frame, and this is the one leaflet, this is another leaflet. The three orifices, I'm describing it because it has some importance. These are two semicircular larger orifice, and this is the one central rectangular orifice. So whenever you do this, consider the hemodynamics, the blood flow through the two larger semicircular orifices are, blood flow is more, but pressure gradient is less. Here blood flow is less, but pressure gradient at velocity is high. So whenever you have to measure any continuous wave Doppler or transvalvular pressure gradient, try to place the cursor of the continuous wave Doppler along the large semicircular orifice. So this is the three orifice, and you have to measure the velocity for this orifice. So biliped tilting disc, I have described it. These are some picture of the bioprosthetic stented porcine valves. You can see these are the stent mounted. This the projected part is done by the stent and have some three leaflets. In mitral position and aortic position, both have three leaflets. Although the native mitral valve is of two leaflets, but prosthetic valve have 3 leaflets. This is the stented heterograph valve picture. These are some picture of the stentless valves. This is the first generation transcatheter Edward Sapien valves, aortic position, and this is the core valve. And this is the biological or tissue valve. These have a average duration of 8 to 10 years. Usually don't need any anticoagulation if it is in sinus rhythm and have no click. But mechanical valve last duration is longer, may last more than 20 years. And some of the studies show that it can last for even 30 to 40 years and need lifelong anticoagulation, and it produces clicks. See the picture of the mitral clip. So this is the picture of evolution of the valve. You can see first star Edward valve implanted in 1961, single disc 1969, bileaflet valve 1977. Homograph. These are cryopreserved human aortic or pulmonary valves harvested at autopsy. And a way of implantation of the prosthetic valve. You can see the bioprosthetic heart valves are implanted either surgically or by transcatheter approach. But mechanical valves are implanted always by surgical approach. Now I will talk some characteristics, that is the normal characteristics of the prosthetic valve. What are the normal characteristics? You can see regarding the prosthetic valve, the blood flow through normally functioning prosthetic valve differs from the native valves in several ways. What are the ways? The effective orifice area is smaller for prosthetic valve because swing ring and occluder mechanism occupies some of the central space, and leaflets of the bioprosthesis are stiffer, so higher resistance to forward flow. So all the artificial heart valves are inherently stenotic. So the range of velocities that must be considered normal varies widely among the prosthetic valve. I will show in the slides and tables how the range of velocity differs and how the pressure gradient differs. Now, role of echo in prosthetic heart valves. What is the role? So it is a non-invasive ability to evaluate both anatomy and function of the prosthetic valve and diagnostic modality of choice for ongoing assessment of the prosthetic valve function. You can assess by echocardiography the type of valve, structure and function of the prosthetic valve. So echocardiography is routinely used prior to valve surgery to make decisions regarding type, size of possibility of the repair, etc. During surgery, to assess the success and completeness of the procedure, and following surgery, to establish a new baseline to document a successful procedure. I have marked level, rate, because it is very important. After surgery, you have to make a baseline study. So, in post-operative period, the baseline echo Doppler study in all patients should be done, such as during the first post-operative clinic visit, usually within 2 to 4 years. But there are other studies, they document or recommend 3 to 6 weeks or even 12 weeks. And this can be used as a reference for future evaluation to help determine whether a given pressure gradient is normal or abnormal for the individual. So the primary goal of echo by 2D echocardiography, we have to determine the specific types of the prosthetic valves, confirm the stability of the swing ring, confirm the opening and closing motion of the occluding mechanism, and evaluate visitations and thrombi. And so you should focus on, by echocardiography, thorough evaluation of repaired or replaced valve, measurements of dimensions of all 4 chambers, and obviously you have to assess the left ventricular and right ventricular systolic and diastolic function, and you have to determine the pulmonary pressure. So prosthetic valve, the most accurate method for detecting the quantifying the degree of prosthetic obstruction is Doppler echocardiography. As usual, Doppler echocardiography is the best method to assess the hemodynamic property of the prosthetic valve. So by Doppler echo, what is the primary goal? You have to observe the color flow imaging to define the location and direction of the various flow patterns. And you have to use the passive and continuous Doppler imaging to quantify the flow velocity. And you have to assess the valvular regurgitation, distinguish transvalvular from the perivalvular regurgitation. This is important. You must be careful whether the regurgitation is transvalvular or the perivalvular or paravalvular. So examination should focus on, very important, the critical part of the evaluation is to determine the pressure gradient of the prosthetic valve. So the basic Doppler principles applied to the native valves are also relevant to the study of the prosthetic valves. And you have to measure both the maximum and mean gradient across the prosthetic valve. So this is the way how to, you have to use the continuous wave Doppler. I have shown the aortic valve, but you can use it on mitral valve, tricuspid valve, pulmonary valve. So determine the maximum and mean gradient, you have to apply the continuous wave Doppler technique. So you'll get this type of image by continuous wave Doppler, then you have to trace it. The tracing will give you the maximum gradient and mean gradient and VTI of the tracing, and obviously you have to mention the heart rate of the valve at that time, because the gradient and velocity, it varies with the rate of with the heart rate. You have to calculate the effective prosthetic orifice area by continuity equation. This is like the native valves, but there is, so this is the way how to assess the effective orifice area of the aortic valve. You have to apply this formula by continuity equation. You have to find out the LVOT diameter. You have to find out the LVOT VTI by placing the passive Doppler and then trace it, and you will get the VTI of LVOT. And you have to put continuous wave Doppler along the aortic valve, and you will get this type of picture, image, and trace it. You will get the VTI of aortic prosthesis, and apply this formula, and you will get the effective orifice area of the prosthetic valve. Now, regarding the prosthetic mitral valve area, how to evaluate? Some of the authors, they advise half time method to calculate the effective orifice area, but most of the authors, they discourage this method because pressure half time yields some larger than higher effective orifice area. So continuity equation is effective for mitral valve prosthetic valve area. So this is the formula that you can apply for all the valves, aortic, mitral, and tricuspid prosthesis, to find out the effective orifice area of the prosthetic valve by continuity equation. So in that case, you have to find out the LVOT area, then LVOT VTI, then the prosthesis VTI. So this is the formula. So whenever you have to go doing echo, when you will apply the, what are the things you will get most important information from transthoracic echo, and what are the information you can get from transesophageal echo. So transthoracic Doppler echo is indicated to assess the hemodynamic severity, and transesophageal echo is indicated to assess the valve motion and clot burden of the prosthesis. So what are the echo features of a normally functioning prosthetic valve? So you have to identify the normal features, then you can understand the dysfunctional valve. So the important early step in the echocardiographic assessment of the prosthetic valve is to recognizing the range of normal findings. And reverberation is the normal findings of prosthetic valve. You can see there is a placement of the mechanical valve, it giving some reverberation, and this hiding the image of the left atrium, and that may hinder some of the mitral regurgitation. This is the diagrammatic picture showing how the mitral valve and aortic valve is causing the reverberation and causing some problem of visualizing, 2D visualizing of some structure behind the reverberation. This is the prosthetic valve, the reverberation like this. This is the mitral valve, this is the aortic valve. But you can overcome it by using different off-axis or different view windows according to your situation needed. So these are the three mechanical valves. Is the high profile, is the lowest profile, and this is the flow product. High velocity in the star ball and case valve. The flows are around the ball. There is no center. And for tilting disc, there is minor orifice and major orifice. So through the minor orifice, velocity is higher. And for bileaflet valve, the central orifice higher flow gradient and the lesser flow gradient in the two lateral semicircular orifice. So these are some normal variant of the continuous wave Doppler spectrum across the prosthetic valve. This is the Star Edward, St. Jude's, Metternich Hall, Cosine, all have mean gradient. You can see 9, 4, 4, 8. All are normal gradient of the valves and shapes are different. So these are the normal variant of the prosthetic valve and differs according to the type of the valve. So this is the spectrum, continuous wave Doppler across the aortic valve of mitral, obviously the mechanical valve. You can see the clicks. These are the clicks. The clicks indicate the valve is functioning normally. And this is applicable for the mechanical valve, not the tissue valve. So there are some, what are the other normal prosthetic valve features? This is the presence of normal or physiologic regurgitation. And this is the unique aspect of the prosthetic valve function. And this is the part of design of the valve to provide a washing mechanism and prevent thrombus formation on its upstream side. And these are some still picture to show the physiological regurgitation of the prosthetic valve. Don't mention it as a pathological regurgitation whenever you do echo. Now, what are the features of the normal or physiological regurgitation? This is the characteristic pattern of each valve type. This is symmetric, brief, non-turbulent, and pathological regurgitation are always like the native valves. So this is the features of the normally functioning prosthetic mitral valve. This is an average figure, not the constant figure. The velocity should be less than 1.9, mean gradient should be less than 5, effective orifice area more than 2, and pressure half time less than 1/3. That makes the normally functioning prosthetic mitral valve. Now, and this is the picture of the normally functioning prosthetic mitral valve. You can see the anti-gate velocity is increased, but pressure half time is stiff. And you can see the prominent clicks. Now, what about the normally functioning prosthetic aortic valve? These are the velocity, that is an average, not the fixed. The velocity less than 3, mean gradient less than 20, velocity ratio more than 0.3, effective orifice area more than 1.2, and time to peak velocity less than 100. That constitutes the normally functioning prosthetic aortic valve. And this is the Doppler, continuous wave Doppler spectral image. You can see here is also anti-gate velocity slightly higher, but it is triangular shape and prominent valves. And this is the normal picture of the tissue valve. You can see the stent or struts are protruding inside the LV. It's normal. And you can see the flow, gala flow. It is striking the interventricular septum. But in case of native valve, this flow goes towards the LV apex. But it is normal for the prosthetic valve. So this is a picture showing the first generation transcatheter aortic valve implanted in a patient with severe calcific aortic stenosis. And this is a very important picture. You can see the first generation Edward sapien valve. This is the core valve. The point of deployment, this is the annulus. It is employed. The lower edge of the stent usually remain 2 to 4 millimeter below the aortic annulus. This is the annulus, and this is the annulus, and this is the lower end of the stent edge. And the valve Bridging of the cusp at the level of the native bulb annulus. This is the prosthetic bulb cusp, but it is at the level of the annulus. But for core bulb, you can see the bulb are supraannular. This is the annulus. This is the prosthetic bulb cusp. So this placement is supraannular, and the stent edge is lower than this. It is usually implanted slightly lower, that is 3 to 6 millimeter below the annulus, and it may cause the impingement of the anterior mitral leaflet and may cause perforation. So there are two important complications of the transcatheter valve, aortic valve. One is regurgitation, another is perforation of the AML. Regurgitation, if there is lack of proper apposition of the stent of the prosthetic valve with the native aortic valve, then there will be gap and it will create some paravalvular regurgitation. You can see the severe paravalvular regurgitation. And in this example, the prosthetic valve was deployed too lower and causing impingement on the anterior mitral leaflet. So there is perforation and leading to severe MR. Now we are talking about the normal characteristics of the normal prosthetic heart valves. So there are a range of velocities that must be considered normal, varies among the prosthetic valve. And there are tables of normal gradient of the prosthetic valves of different valve sizes. And this is very important. You can see, I will discuss one table. You can see the aortic prosthesis, bioprosthetic stenting. This is the Carpenter-Edward, this is the Hancock tool. This is the same size, 21 size, this is 21 size, different band. But the mean gradient is different. Here it is 17 is the mean gradient acceptable normal for this valve, but here it is 15 acceptable for this valve. But one thing you can consider, if you add 17 plus 6, it will be 23. 23 is the moderate gradient for the native valve. So for the prosthetic valve, it is the mild to moderate stenotic gradient is acceptably normal for the prosthetic valve. So what is stenotic gradient for the native valve? It is the normal gradient for the prosthetic valve. That is the main important message. And each and every textbook you will get this type of table. And for each and every types of valve, there are table of nomogram. So you can reference it. After the completing your prosthetic valve echocardiography, you have to reference with this table. These are different tables. I will not go details to this. So now, what are the characteristics of the dysfunctional prosthetic valve? Keeping in mind the prosthetic valve is inherently mild to moderately stenotic. So we have to proceed with the evaluation of the dysfunction of prosthetic valve. So before starting the echo, the ideal is you have to have some clinical data on the size and type of the prosthesis, date of implant, heart rate, blood pressure, body surface area, and always compare the baseline echo study. But in our clinical practice, clinical scenario, you will not get any of the parameters in your hand. Most of the time, you have to do echo double blind. So you must be very efficient. And even there will be previous echo report in your patient in the hands of your patient, he will not show it. So you have to assess the dysfunction of the valve. What are the dysfunction of the prosthetic valve? Structural failure, thromboembolic complications, and endocarditis. And what are the mechanism for the structural failure of the bioprosthetic valve? Because they face a slowly progressive tissue generation with fibrocalcific changes of the leaflets. So this results in increased resistance to the opening that lead to stenosis or failure to coagulate, and that lead to regurgitation. So bioprosthetic valve, the typically failure of the tissue valves occur 10 or more years after valve implantation, and acute bioprosthetic valve stenosis is rare. And this is a picture of the structural deterioration of the bioprosthetic valve. So there is failure related to mineralization and collagen degeneration of the valve, and there is a cuspal tear and perforation. And this is another example of the structural valve degeneration. This calcification of the nodule, reduced orifice, commissural tears, and thickened and stiff cusp. This is an example of the prosthetic valve. This is the normal prosthetic valve. And there is valve stent disruption, stent fracture, leaflet tear, and leaflet calcification. Another example of paravalvular leakage, leaflet thrombosis, and infective endocarditis. Now, what are the mechanisms of the structural failure of the mechanical valve? Mechanical valve stenosis or regurgitation is due to thrombus formation or panacin growth around the valve, impairing disc excursion or closure. And there may be other structural failure like faulty design or wear and tear of the prosthetic material, resulting in disc escape or incomplete valve closure. These are rare nowadays. And now the incidence of the prosthetic valve obstruction estimated is 0.1% to 0.4% per year, and it depends upon the size, type, location, and adequacy of the anticoagulation. So the mitral valve mechanical prosthesis obstruction caused more frequently by thrombus, and aortic mechanical prosthesis obstruction caused mainly by panus formation. So this is an example or still more picture of the thrombus of the mechanical mitral valve. This is the obstructive thrombus. These are the picture of thrombus. This is again thrombus. This is the picture of the bilateral valve with panus formation, very angry looking. This is the panus formation. So complication of the prosthetic valve, you need to keep in your mind. Early complication of paravalvular leak, thrombosis or struck occluder, low output state, LVT obstruction, infective endocarditis, patient prosthesis mismatch. And these are the late complications: structural valve deterioration, thrombosis and thromboembolism, bleeding, panacin growth, paravalvular regurgitation, infective endocarditis, patient prosthesis mismatch, hemolysis, pseudoaneurysm formation. So this is a wonderful picture. The two different spaces residing on one platform, like the prosthetic valve in the human body. So approach to evaluation of the prosthetic aortic stenosis. I will go some individual valve. So how prosthetic aortic valve dysfunction can be determined. So these are the parameters that you have to measure to decide about the dysfunction: anti-gate velocity across the aortic valve, mean pressure gradient, effective orifice area, and ratio of the LV outflow to aortic velocity, that is DVI. And always these should be referenced to the normal values for each valve type and size, and should be referenced. So how to measure the DVI that I have shown it. I think you know it. And so just to calculate the DVI for the learner I am talking it, you have to make a continuous wave Doppler across the valve, aortic valve, and take an pulse wave Doppler of the LVOT and find out the VTI, then just ratio it. That is the DVI. That is the DVI. And this is the continuous wave Doppler across the valve. This is the aortic valve TVI is 103 and LVOT TVI is 103. Just ratio it, that will yield with the DVI, Doppler Velocity Index. So these are the features, a parameter of the severe stenotic prosthetic valve. The velocity more than 4, mean gradient more than 35 millimeter, velocity ratio less than 0.25. And mind it, the morphology of the valve or spectral image, it is rounded, late peaking velocity curvature, and effective orifice area is less than 0.8 square centimeter. So these are the features of the severe regurgitation of the prosthetic valve. These are like the native valve. I will not go details to this. So whenever you get this stenotic gradient across any prosthetic valve, you have to think some differential diagnosis. What are these? You have to think about the high cardiac output state, as per example, anemia, fever, hypovolemia, thyrotoxicosis. And you have to differentiate this high volume state from the genuine prosthesis, prosthetic obstruction. Next is the significant regurgitation, patient prosthesis mismatch, pressure irregularity like this. So if you get a severe stenotic gradient across the aortic valve, now think about whether the increase in transvalvular peak velocity and mean gradient is due to pathological valve obstruction, or due to high flow state, or regurgitation, or patient prosthesis mismatch. To solve this differential diagnosis, you have to measure the other parameters. What are the other parameters you have to measure? You have to measure the acceleration time, ejection time, calculate the this ratio of the two, acceleration time and ejection time, and then calculate the LVOT TVI and aortic valve prosthesis TVI. So this is the way how to calculate the acceleration time. You have to measure from beginning of the spectral image to the peak time. So here is the acceleration time is 58, and this is the ejection time from beginning of the spectral image to the end of the spectral image. So this is the ejection time, and make it ratio. Here is the ejection time is 58, and ratio is 0.3. Here you can see this is the image of the severe stenotic valve gradient. You can see 80 is 126 and ratio is 0.45. And this is the round appearance. This is the ugly the appearance, the bad is the man. So the round appearance, the severe is the stenosis. So for aortic prosthetic obstruction, AT is prolonged more than 100 millisecond, and AT is to ET is increased more than 0.37. But for high flow state and patient prosthesis mismatch, mind it, these are remain within normal limit. And to differentiate the aortic prosthesis obstruction, the VTI TVI is less than 0.25. But for regurgitation, paravalvular regurgitation, the TVI ratio remains normal. It is more than 0.13. So this is the algorithm how to evaluate the prosthetic aortic valve dysfunction. I will not go details to this. I have discussed already. So this is one example of the aortic valve prosthesis with dysfunction. Example is that this is the baseline study of the patient that was taken within 4 weeks after valve implantation. And when the patient comes with the congestive heart failure, then again the Doppler study was done. The baseline Doppler in here the maximum pressure gradient is 31, and after the symptom of congestive heart failure, the maximum pressure gradient is found on 123. So this is the dysfunction, how the baseline echo study can help you to decide about the abnormality of the prosthetic valve. So approach to evaluation of the prosthetic mitral valve. What are the parameters you have to measure? You have to measure the anti-gate velocity, mean pressure gradient, effective orifice area, and pressure half time. And always normal values for each valve and type and size should be referenced. So for severe stenosis, these are the parameters. Anti-gate velocity must be more than 2.5, mean gradient more than 10, effective orifice area less than 1 square centimeter, pressure half time more than 200 millisecond, and the VTI of the mitral prosthesis and VTI of the LVOT should be more than 2.5. So this is the way how to measure the DVI of the mitral prosthesis. You have to trace the continuous wave image, and you have to trace the LVOT pass wave Doppler image. Then you will make it ratio and get the DVI. And this is the way to measure the pressure half time. So these are some parameters to evaluate the severe regurgitation, whether it is like the native valve, but one important difference is that for PISA or vena contracta is for the prosthetic valve more than 6 is abnormal, but for native valve it is more than 7. That is abnormal. That is the only difference. Other things are similar. Now for prosthetic mitral prosthesis, if you got the increased peak velocity and mean gradient, now again, you have to find out the differential diagnosis of this situation. You have to think of genuine pathological valve obstruction, high flow state, regurgitation, patient prosthesis mismatch. And to differentiate, do measurement of the pressure half time. So if the pressure half time in mitral valve or tricuspid valve obstruction, pressure half time will be increased, that is will be more than 130 millisecond. And for high flow regurgitation and patient prosthesis mismatch, the pressure half time will be lower, that is less than 130 millisecond. So this is two examples. This is the high flow, high gradient across the prosthetic mitral valve with short pressure half time, but for valve prosthesis, there is prolonged pressure half time. So this is the algorithm how to measure the prosthetic mitral valve. I have talked it already. And regarding the prosthetic pulmonary valve.
Dr. Kabiruzzaman,
Sir,
can you explain the previous slide? You take some minutes. The algorithm. Can you explain just for 2 or 3 minutes this algorithm?
okay, sir, I have shown it in the previous slide because it's normal parameters and these are the severe parameters. In between these, the high gradient that may make you think about the patient prosthesis mismatch or the high flow gradient. That should be differentiated by the, for the mitral valve, it should be differentiated by the pressure half time. And for the aortic valve, you have to measure the ejection time and the acceleration time and to make it the ratio of this. That is the main thing to differentiate about the genuine prosthetic valve obstruction and to differentiate the high flow state and regurgitation. I have explained all the components individually. That's why I have escaped it, sir. Okay, sir?
Okay. Thank you.
So for pulmonary valve prosthesis, how can we differentiate the severe gradient? It's only the velocity. It is the, for tissue valve and mechanical valve, it is more than 3 is the severe stenotic gradient. And for the 2 millimeters is the homograft. And these are the features for the severe regurgitation of the prosthetic pulmonary valve. This is the similar to the native valve. And these are the parameters for prosthetic tricuspid valve. These are the stenotic gradient of the severe stenosis of the prosthetic tricuspid valve. Mean gradient should be more than 6 millimeter mercury. It is mitral valve, it is 10. And these are the parameters for the severe regurgitation of the tricuspid prosthesis. And this is the biprosthetic tricuspid valve with severe stenosis, with severe gradient. Actually, it is the 2D inspection and the Doppler gradient. That is the main clue to decide about the severe stenotic gradient across the prosthetic valve. And this is again the prosthetic tricuspid valve. You can see the three peaks. These are due to atrial fibrillation. And this is the biprosthetic pulmonary valve stenosis. Actually, this boy, it is a 34-year-old man. He had a total correction for tetralogy of Fallot in the childhood. And that time he was implanted the tissue valve at the site of the pulmonary valve. That get degenerated and calcified and yielded severe stenotic gradient. And that was being relieved by valve-in-valve prosthesis. This is the valve-in-valve prosthesis. So there are many technology to insert inside the human body to prolong the life. Actually, all prosthetic valve that can prolong the life, but cannot achieve the normal life expectancy. But that is also good. So I will talk few words regarding the patient prosthesis mismatch. Actually, this is some surgeon's issue. So what is the primary echocardiographic clue to decide about or think about the patient prosthesis mismatch? You will get high valvular gradient with normally functioning valve. Your cusp are moving in fantastic way, good way, but you will get the high gradient. Then patient prosthesis mismatch is present when the effective orifice area of the inserted prosthetic valve is too small in relation to the body size. And these are the parameters of patient prosthesis mismatch. Severe mismatch orifice area is less than 0.65 square centimeter per meter square, high transvalvular gradient, persistent ventricular hypertrophy, increased rate of cardiac events after AVR. So these are the classification of the aortic PPM. It is not the permanent test figure, it is the patient prosthesis mismatch. So it is the valve area that determine the mild, moderate, severe or the insignificant, moderate, severe, not the transvalvular gradient. So mind it, and you have to find out by continuity equation. And these are the mitral PPM as classified as insignificant, moderate, and severe. And to avoid or prevent patient prosthesis mismatch, there is some formula. This for aortic valve and this is for mitral valve. And choose and implant the prosthesis with effective orifice area larger than the effective orifice area calculated in this step. So this is a table of nomogram to choice about the valve size of different valves. You will find it in the Kirkling surgery book. So to avoid the patient prosthesis mismatch, choose the valve prosthesis with adequate indexed orifice area based on patient's body size and annular dimension, and aortic annular enlargement or other approaches to allow implantation of an appropriately sized valve or avoidance of prosthetic valve. So patient prosthetic valve dysfunction, there are other modalities of investigation that you can use other than the echocardiography. You can use the cinefluoroscopy, cardiac CT, PET CT, stress echocardiography, and cardiac catheterization. So I will show some video clip to show you some complication. This is the dehiscence and vegetation. You can see the bileaflet prosthetic valve, it is opening and closing very in fantastic way, very good, the normally functioning valve. But there is dehiscence in the annulus, and you can see the dancing and oscillating movement of the vegetation, and you can see. So this is the example of the dehiscence, the dancing movement and oscillating movement of the annulus. And this is the same patient with the color Doppler image. This is the severe valvular, paravalvular regurgitation. And sorry. Sorry, I was interrupted. So this is the same patient with the paravalvular regurgitation, the dehiscence of the valve. This is another picture, the Star Edward case valve. We can see this is the normally functioning. The color flow are flowing around the valve. You can hardly see the movement of the valve, and there is some aliasing of the color flow because all the stenotic valve, all the prosthetic valve are stenotic. And this is the picture of the cine loop of the malfunctioning mechanical valve. The movement of the valve is hardly seen. Observe, there is a severe transvalvular gradient. And this is the normally functioning bileaflet prosthetic valve in mitral position. There is good well visualization of the movement of the valve, and the gradient is the mean gradient less than 2. But there is another feature, the dysfunction of the LV. And this is the paravalvular aortic leak. And this is the tissue valve in the mitral position and the normally functioning. You can observe the movement of the leaflet. This is the color flow. And this is the bileaflet prosthetic valve in the aortic position. The leaflet, movement of the leaflet is well visualized. And this is the tissue valve in the mitral position with vegetation. You can see the angry looking vegetation with oscillating and dancing movement. And this is the independent to the movement of the leaflet. That is the vegetation. And this is the single disc. That is the prosthetic mitral valve. You can see the movement, characteristics movement. It was implanted in 1999, and I started it in 1919, 20 years back. So miraculous. It's the same patient, it's color Doppler. You can see, although there is aliasing of the color flow, but stenotic gradient is within normal limit. And you can see the valve clicks. Patient was in atrial fibrillation. And this is the cine loop of the stuck valve, bileaflet valve. And this is the picture after giving the streptokines, same patient. So take home messages. The size of prosthesis and record of the valve gradient immediate post-operation should be known. Take time and patience, use multiple conventional and off-axis echo windows. Try to evaluate movement of the prosthetic leaflet and thrombus or mass. And carefully observe the color flow imaging through the valves and for paravalvular regurgitation. Take continuous wave Doppler spectral images to calculate maximum and mean gradient of the valve. Compare PVG of P pressure gradient and mean pressure gradient with the nomogram table of the prosthetic valve. Calculate the effective orifice area of the valve very carefully. And mention the heart rate and rhythm. Mention about the complications if found, and make conclusion whether the valve is functioning normally or the valve is or there is dysfunctional valve. Now, this is the wisdom implies the timely and rightful application of knowledge, and knowledge may even be a pitfall or an encumbrance unless you learn to use it justly. So thank you all for patient sharing. I've taken time. So,
Thank you, sir, for the excellent presentation. I think everyone has enjoyed this much. Now is the time for question answer session. I have a few questions in the chat box. One question was whether we can assume that a patient is having patient prosthetic mismatch clinically. This was from Rajiv Ghosh.
actually, clinically, it is very difficult to say because there is one clue. If there is metallic bulb, you can see the good sound of the prosthetic bulb. But if the patient comes with the features of the failure, or patient is uncomfortable, patient is giving you the clinical history of the stenotic gradient. So features like the severe valvular stenosis that you can gauge clinically. But if there is tissue bulb, then you cannot gauge it clinically. You have to do echo.
Regarding the patient process measures, I have got an experience. I have got a patient who was treated with prosthetic valve, metallic prosthetic valve at the age of 15 years. Now he is 30. He's grown up. His valve leaflets are looking fine, but there is a pressure gradient, aortic valve pressure gradient around 50, and he is symptomatic. Is this patient process mismatch?
Definitely.
Definitely.
The age
So
of
this is a clinical clue.
blood, yes. Now, clinically, actually, you can gauge it, but if you want to document it, then echocardiographically, you have to see the valve is moving normally, and there is high gradient.
Thank you, sir. What are the additional points that should be mentioned on echo before aortic or mitral valve replacement?
Aortic or additional point, what does it mean?
Additional points that should be mentioned in echocardiography before aortic and mitral valve replacement.
Additional point. Okay,
Additional
pre-surgical echo. Pre-surgical echo, what are the points should be mentioned?
We are talking about after replacement.
Okay, before it's an important one. Actually, we have to mention about the very carefully the valve annulus. Surgeon will assess according to your measurement of the valve annulus. But another thing, surgeon should decide which valve he is to put it. He have the nomogram in front of him in surgical books. He should study it. Whatever you mention in your echo, that may be wrong. But surgeon should assess, have another assessment regarding the body size and age of the patient. Echocardiography wise, pre-surgical echo, you have to mention very carefully the valve annulus. For mitral valve, you have to mention two sides. One is the apical 4-chamber view, another is the apical 2-chamber view. And you have to take that measurement whenever you can see the hinge point of the both leaflets, then you have to measure it. And in mid-diastole. And for aortic valve, you have to measure the different dimension. You have to measure the aortic annulus, sinus, sinotubular junction, and the ascending aorta. And mind it, you have to scroll it different images, and you have to take time to decide which one is the bigger size, because it's a moving structure. So many of the times the patient takes respiration in different way. So you have to be patient, and you have to pay some time and attention to measure the annulus. Thank you.
Thank you, sir. What is the position of sample volume to get prosthetic valve VTI? This has been asked by Dr. Azizul Haq Sohel.
VTI for aortic valve, actually for VTI for the prosthetic valve, you have to put the continuous wave Doppler and make sure which one is the maximum gradient. To look for maximum gradient, you can choose the different windows of the echo. And you have to make alignment of the color images of the prosthetic valve. That will take some time because reverberation will disturb it. disturbed to find out the prosthetic valve curve flow image beyond the valve. So you have to make some adjustment or off axis or other axis like this.
As sir, nowadays most of the valves implanted are bileaflet valves.
Okay.
Certainly, we have to avoid the central orifice. We have to
Okay.
go towards the peripheral orifice for interrogation of the VTI. Am I correct, sir?
No, yeah. Okay, for prosthetic bileaflet valve, yes, it is the grammar. You have to put the two lateral orifice, not the central orifice. I have seen in my practical life that someone is commented about the high gradient prosthetic valve dysfunction, malfunctioning prosthetic valve. And I see the leaflet is moving very, but I got to the normal gradient. Then I thought that there may be some that echocardiographists may have the place in the central orifice. Then I take time to make alignment of the central orifice, and I got that gradient. And that was my student. I have talked to him. And yes, you have did the right things, but you have to put in the like this. Actually, it is the mean gradient. Whenever you have to put the continuous wave Doppler across the prosthetic valve, it is the mean gradient that is important. That is important. And you will get the BTI by mean gradient.
Thank you, sir. One question from Dr. Rahatul Kadir. If there are two regurgitant jets in case of prosthetic valve regurgitation, which one should be used to measure vena contracta?
Actually,
In case of,
in these cases, there are two vena contracta, two regurgitant jets. You can use the both measure, but you have to observe the effect, hemodynamic. Main thing is that you have to effect the hemodynamic effect of the regurgitation. If the hemodynamic effect is causing the enlargement of the left ventricle, that is severe.
does same principle apply for the paravalvular and the transvalvular regurgitation?
Paravalvular and transvalvular has same principle. No, sir.
But in case of multiple regurgitant jet, this jet area is not that much applicable. On that case, regurgitant volume and regurgitant fraction is the thing which you have to calculate.
But multiple jet, again, the regurgitant volume measurement is a cumbersome job.
Cumbersome one.
But you have to rely on the volume of the LV.
Right now, there are no questions in the chat box from the participants.
One question.
So,
one question.
Sir.
Yes, sir. Yes, sir.
Dr. Kobi, how
Sir,
to
sir.
differentiate impulse from the penas echocardiographically?
Actually, sir, echocardiographically, thrombus and penas differentiating is the frustrating job. Sir. Frustrating job, but because both the things are deposited on the periannular area. There is most of the time they have the annular fabrics and the metallic part of the stent like this. So imaging become the very cumbersome job. So it is the CT with the good option.
But there are some differentiating features.
But is there any softening?
Actually, these are the theoretical. But
Ecogenicity?
yes, I am talking
About ecogenicity?
Actually, ecogenicity wise, it is the dense. If you think about the
penas,
histological structure, the penas is composed of the elastic tissue and collagen.
Yes.
Thrombus, fibrin and the red cells and the platelet like this. So these are the soft tissues. So the ultrasonogram ecogenicity will be different. That is a theoretical issue that I'm talking. But in real life, if it is on the top of the prosthetic valve, then you can differentiate it. It is thrombus. Because penas will not come to the tip of in the central position. That is the common sense everyone is applying in the real life. Okay. That is the differentiation point.
Position of the valve is also important because the thrombotic occlusion usually used to occur in the mitral valve prosthesis, and in aortic valve prosthesis, dysfunction usually occur due to penas syndrome.
Yes. I have talked in this.
Difference between physiological and pathological.
May I ask Kabiruzzaman sir another question?
Yes.
Sure, sir.
By echocardiography, you are able to determine the type of the valve, whether it is ball and case variety or single disc or biliped valve. Although the
Yeah.
biliped valves are now commonly implanted, but yet then the valves with case ball variety as well as the single disc varieties are also coming to us for evaluation. So this is also important. Can you differentiate the echocardiogram?
Yes, yes. And echocardiography is the modality of the choice. You have to decide the type of the valve. But you should have some preclinical after surgery parameters. And I have shown all the slides, video loop that I have taken from my clinical practice. You can easily recognize the ball valve, case ball valve. You can easily differentiate the tilting disc. These are the valves it can be easily differentiated. But regarding the tissue valve, you cannot differentiate the brand of the prosthetic valve. And sometimes it happens if there is a stentless prosthetic valve, if you don't know it, there is valve. If you don't look for the sternotomy, you will miss it. And this happened in our institute also.